The next session would be a panel discussion on approach to genetic testing in children with developmental delay. I request the moderator, Dr. Kalpana Gowrishankar, to take over the podium, and the panelists of this session, Dr. M. Pradeep Kumar, Dr. S. Kiruthika, and Ms.Brinda Ramanathan, to occupy the dais.
At the outset, I'd like to thank the organizers of GDP Con for asking us to be part of this August occasion. I feel very proud to introduce my dynamic panelists. We have Dr. Pradeep Kumar from Coimbatore. He's a pediatrician who has done a fellowship in genetics, and he has had many years, and I know he's very, very dynamic and excellent geneticist. We have Dr. Kiruthika. She's from Salem, and she's also a pediatrician with a fellowship in genetics, clinical genetics. And last but not the least, we have Ms.Brinda Ramanathan. She's our genetic counselor and a very important person who in part today's discussion. We are going to start the session with a number of case scenarios, and we'll start with that. We all know that pediatricians are the first contact for parents with children with developmental delay, and sometimes it's the unfortunate, often the pediatrician who spots a delay and has to break the news to the family. It's a common problem. It's seen in about 1 to 3% of the population, and genetics plays a big part in developmental delay, and there are myriads, a lot of genes, over 2,500 genes have been implicated causing developmental delay. Taking genetic diagnosis gives a unique opportunity for interventions as well as preventing morbidity, further morbidity. So we'll start with the first case. This was a 1 year, 7-month-old child who is brought with a history of developmental delay and typical dysmorphic features. The antenatal, natal, postnatal period were normal, and the child presented with developmental delay, so the delay was picked up by the pediatrician and testing was done, and you can all see the dysmorphic features in the child with the angulated broad thumb and the broad big toes. Now with this, my panelists will be taking over. My first question to Dr. Pradeep would be, any particular diagnostic handle in this child's phenotype would you like to describe?
Yes, ma'am. Thank you, ma'am. Thanks organizers for this wonderful opportunity. So here we have a child with developmental delay, 1 year, 7 months old. All other things were normal, uneventful pregnancy and delivery. And again, no seizures, but baby has facial dysmorphism. You can, handle-wise, we can divide into major and minor handle. Major handle, obviously here is a global developmental delay, is a major handle for us. And minor handles are small subtle dysmorphism, what we find in the baby. Say broad, you can see that broad forehead, there is a small epicanthic fold, broad nose, thin upper lips again. But again, there is a pointer here in the thumbs and great toes, widened, broad, angulated, broad thumb and great toes. So these are minor handles, but again, these findings gives us some clue about a genetic disorder. So major handle, developmental delay, minor handle, subtle dysmorphism. With this, we can think of some differential diagnosis.
Dr. Kiruthika, do you have any differentials for this phenotype?
Thank you, ma'am. Thank you, organizers, for this opportunity. So yes, when we consider the major and minor clinical handles as pointed by sir, we have a lot of associated syndromes with thumb anomalies which has a developmental delay as features. Like when we see a child of this phenotype with angulated thumb, we generally think of Rubinstein-Tebe syndrome. The other associated syndromes which we think are the craniostenostosis, where we can have an abnormal shape in the skull associated with thumb or a great toe features such as Pfeiffer syndrome or an upward syndrome or Seter-Choudhury syndrome, or you can think of other systemic involvement such as a cardiac feature seen with an Holt-Oram syndrome, or a Fanconi anemia where there is a pancytopenia with a radial ray defect, or any kind of skeletal dysplasias like diastrophic dysostosis where there is a hystriker thumb. So the list keeps on increasing with the clinical phenotype, but we need to make sure of the more clinical handle here.
Yeah.
Thank you.
Now you have a baby with dysmorphic features, developmental delay, and characteristics, big thumbs and big toes, broad toes. And with this, what test would you consider, Dr. Pradeep?
Okay, so we have a big list of differential diagnosis. How to filter among these? So each and every positive point has a value, negative point also. Say not having cardiac abnormality, not having skeletal abnormality, not having pancytopenia. All these things will help us filtering the differential diagnosis. So obviously all the other features were not there. And this typically, if you see a baby with Rubinstein TV, it is a common disorder you see in pediatric practice also. So I would stick on to Rubinstein TB first again. So I would order, so for Rubinstein TB, the testing option will be gene sequencing, which is what is going to yield us the best result. So CREB-BP and EP300 are two genes involved, and most commonly we get point mutation sequencing abnormalities. So I would prefer doing a gene sequencing for Rubinstein TB if that gene sequencing panel includes all other genes given in the differential diagnosis. That will be well and good for me.
So you've decided on going for sequencing. I now call upon our genetic counselor. So the family comes to you before ordering the test. What kind of counseling how would you like to prepare the family for this testing?
Thank you for the question, and thank you, organizers. So this is typically a pre-test counseling. So we have narrowed down on the differential diagnosis based on clinical parameters, major and minor handles, and based on that we have also zeroed down on the test of first line of investigation in genetics. So if we consider exome sequencing, we are looking at the exome part of the area. So we will have to explain this aspect to the family that we are not doing a pan-genomic test, we are covering a small area where we are expecting a certain proportion of results to come. So we set the expectations right with the family, and also talk to them about the possible outcomes. So there can be a positive outcome, there can be a negative outcome. We might not get an uncertain result. So make that a realistic expectation out of the test for the family. Address side by side the emotional anxiety also, that goes without saying, and also talk about incidental findings. So we are going for a larger span of area in the DNA, testing a larger span. So in that regard, there is a possibility that we will come across certain variations that was not originally intended to be tested for. So setting that, preparing them that this is a possibility. If that is the case, would you like to be aware of it, and then take it through them with that aspect. So this is predominantly what pre-test counseling constitutes: setting expectations right, talking to them about the limitations of the test. If required, further testing might be required, and so on.
This is the sequencing report that we got. I request Dr. Pradeep to interpret this genetic report. What should a pediatrician, when you get a report like this, what should each one of you look at it? How do you look at it and interpret?
Yeah. Gene responsible for Rubinstein, we have found out CREB-BP is the gene, we know, and there is a point mutation, that is a small deletion that is found, that is the variant, and it is in heterozygous status. Autosomal dominant, we expect this is an autosomal dominant situation. Autosomal recessive, we expect a homozygous mutation, and most importantly the pathogenic classification. It is class 1 pathogenic classification. That means almost we have nailed the diagnosis. There are other class 2 and class 3. Obviously most of the time we see VUS which are class 3, that, and again it goes on like likely benign and benign. So class 4 and class 5, all these are they become very weaker, but this one is a stronger mutation we have found out, and this has nailed the diagnosis. There they have given two diagnoses there, Menke-Hennekam syndrome and Rubinstein-Tabi. Now we have to apply our phenotype-genotype match. So what syndrome is exactly fitting in with our patient. So obviously Rubinstein-Tabi is fitting in. Menke-Hennekam will have severe developmental delay, seizures, flat faces, not the broad thumbs and all. So typically phenotype is not matching. Here is an example. One gene can give rise to two genetic disorders, but we should be clear what genetic disorder we are dealing with. So almost we have nailed the diagnosis. If this is a positive case, lucky case, developmental delay, we've got a clinical sign, we went ahead doing the testing, we got it positive. Many a times we may miss the bus, we will not get the results, then we have to think whether our diagnosis is right. Next thing is whether the gene is completely covered. So CREB-BP sequencing abnormalities detect about 80%. If you are very sure it is Rubinstein-Tabi, you are not getting the answer, then we may need to go ahead do the deletion duplication, which may cover around 20%. So if this result is negative and we are very sure about Rubinstein-Tabi, I would order MLPA for CREB-BP to look for deletion duplication, which constitutes about 20%. So all these knowledge base should be there to interpret testing. If it is clear, straightforward, it is easy. If it is doubtful, then we need all these knowledge base to help the patient.
Thank you. Brinda, would you like to add what kind of counseling post-test, now that you've got the report and it fits with your case? So when the family comes to get the report, how would you counsel?
So I would just extrapolate on what Dr. Pradeep just mentioned right now. So interpret the report as such in more layperson's terms, terminologies for them, and discuss the possibilities. So I think in the previous slide the couple were young, so they may, and it's a single child, it's a first child. So are they planning for another, for another pregnancy? So discuss clinically, do the parents need to be evaluated for such a clinical profile to check for a slight variation, because with autosomal dominant conditions what happens is there's something called variable expressivity. So there is a very bleak possibility, it's usually de novo, but there is a bleak possibility that this could be inherited. So if that is the case, we would like to refer them back to the clinician, get a round of checking done by them, and then go ahead with prenatal or antenatal counseling.
Thank you. We move on to the next case. So the diagnosis in this case is Rubinstein-Tabi syndrome. The second case is an 8-year-old boy. He was brought by his parents who were first cousins, and this child, even as he entered the clinic, he was very, very hyperactive, and that was the concern of the family. They could not handle him. He was so hyperactive, he was so restless, he was biting things, biting paper, and they are first cousins, as I said. The antenatal, natal, postnatal period was normal. Initial developmental period, initial thing, he was a slow child. But as he grew, they found that there was a deterioration in his gait. He was walking, he was getting very clumsy. He was also very, speech was getting, he was losing speech, and he was, the most important factor was his hyperactivity. The parents came with a Fragile X testing done, it was negative. So that was ruled out. Examination, if you look at him, you can see that he has mildly coarse face, his eyebrows were very thick, and he had also a jutting out big low lip, and the corneas were clear. My first question would be to Brinda. What is the important feature in this pedigree in the context of this child?
So I think we are seeing a double line. The marital line has a double line, meaning there is a consanguineous marriage, a marital relation. So we have a sizable reason to suspect, as one amongst many, an autosomal recessive condition. So we need to keep that in mind while we decide further on the diagnosis angle as well as the testing angle as such. So one is the consanguinity, autosomal recessive is one possibility. Yes.
Doctor, the next question is to Dr. Kritika. What would your, in this scenario, consanguineous parents, a child who is little slow to develop and then regresses, and he is very hyperactive, he's got coarse features. So what would you think of the differentials in this child?
Thank you, ma'am. So I would think more of a storage disorder, that is more specifically a lysosomal storage disorder here, being the possible clinical phenotypes of coarse faces with the hyperactivity and neuroregression here. There are other differentials also to be considered, but foremost we need to rule out the treatable condition, that is a congenital hypothyroidism in any child with a coarse face. So when the things are ruled out, we need to think of other differentials. That includes GM1 gangliosidosis, other disorders like mucolipidosis, and then alpha mannosialidosis and galactosialidosis. The list keeps increasing with the storage disorders, and all these disorders tend to have a more pronounced phenotype in the newborn period itself.
Yeah.
Thank you.
But this, in this scenario, he was, newborn period was essentially normal.
Yes,
he
ma'am.
was slow and then deteriorated.
Yeah.
So with this in mind, Dr. Pradeep, what special investigations would you like to do for this child?
Yes, ma'am. So, as enumerated, she has enumerated the differential diagnosis. So, we know we are almost fixing in with storage disorders, possibly macromolecular, it is not micromolecular. Facial changes have started, bony changes have started. Hirsutism with coarse facies, umbilical hernia, child deteriorating, gradually he is deteriorating. All these favors the diagnosis of lysosomal storage disorders. Mucopolysaccharidosis will come to my mind first, and doing extra investigations to narrow down our differential diagnosis again. There are so many types of mucopolysaccharidosis. Doing an eye evaluation, cornea is not cloudy, again we can rule out Hurler, we can rule out Hunter. So bony dysostosis is not so severe, then we can think of type 3 or Hurler-She, the very milder form. So the features which are present or absent in mucopolysaccharidosis, that will give us a clue. So for this child I would advise X-rays, particularly to look for widened ribs, bony changes in the spinal cord. Maybe if it is available, gags will give us some idea. Quantitative analysis of urinary gags, that is, that can give us an idea, but again, that cannot be taken as a dictum. If it is negative, you cannot rule out MPS also. Sometimes there may be changes because of dilutional. If available, electrophoresis for urinary electrophoresis for gags, again, it will give qualitative. That is, what type of metabolite is he excreting, that can be given. Next option will be enzyme analysis. So enzyme analysis, say if we think of Sanfilippo type 3 MPS here, based on the history, there are 4 types, again 4 enzymes. Each enzyme, their cost will be high. So we have to work out based on cost also. So spending so much on the enzyme, they may not be affordable later for genetic evaluation. Once we have clinically found out all these, we have narrowed down our differential diagnosis. If possible, confirm by enzyme analysis. If enzyme analysis takes too much of cost, then we can proceed with exome sequencing, do the genetic evaluation for this child. Particularly for this child, we will narrow down to MPS type 3, ma'am. Give an autosomal recessive background with slow progression, more of cognitive.
Yeah. Thank you. And my question to Brinda would be, this is this finally turned out to be type 3 as Sanfilippo syndrome, type 3 MPS. And in this situation, what kind of counseling would you do in autosomal recessive conditions?
Okay, thank you, ma'am. So in case 1, we saw autosomal dominant, where there is, if at all, if you're excluding de novo, the chances of inheritance or a repeat of it will be 50%. But in case of autosomal recessive, there is a 25% chance of recurrence. But the catch here is that because of the consanguinity, they might share a lot more other areas of their genome, just common haplotypes, apart from just MPS alone. So we would ideally recommend carrier screening to rule out if they are carriers of common recessive conditions, and if they are going for another child, counsel them about taking up a carrier screening test prior to planning a pregnancy. We now move to the next case.
This was a 5-year-old child. He was brought by her mother because of developmental delay. Again, the antenatal, natal and postnatal period was normal, and early developmental delay. There is no history of seizures. Examination found a child with a very clumsy gait, mild facial dysmorphism. She had small palpable fissures. Her head was relatively small. She had a fifth finger clinodactyly and generalized joint laxity and sandal gap. Nothing very specific. All you have is a child who has subtle dysmorphic features and developmental delay. My question to Kritika, Dr. Kiruthika, would you, in this scenario, what type of genetic test would you first consider?
Thank you, ma'am. So as pointed by you, there is an unrecognized etiology here underlying. We can't pinpoint her into any specific syndromes or any kind of neurodegenerative disorders happening here. So it is an unrecognized etiology, a child with a developmental delay and subtle dysmorphism. Then what we need to consider is, as per the American College of Medical Genetic Guidelines, the first line of investigation is to be a chromosomal microarray analysis here. So I would preferably offer a chromosomal microanalysis where we do a high resolution entity here.
So we did just that, and this is a report. This is a family, as you can see. She's the first child, and the report is on the left, and I request Dr. Pradeep to do the interpretation.
Okay, ma'am. There is if you see here, there is copy number variation detected that is likely pathogenic. That means it is just microarrays weighing the genome of the patient with the normal person. So comparing that, they've concluded that there is a copy number variation. There is a loss here. They mentioned here the loss is there, and it corresponds to 2q region. So it is a 6.7 MB loss. This definitely cannot be picked up by karyotyping. So microarray was the best option, and because of that it has been picked up. So what does it mean is, there is a piece of chromosome that is missing which will contain this much amount of genes. So this much amount of genes have gone out. All the works, the function these genes has to do in the body will not be functioning. So the phenotype also, it may be very varied because we don't know how these genes will express. Many important genes are there, including your KCN. Okay, so multiple genes are there. Each and every gene will have its own manifestations. So clear, obviously there is a loss, and it is picked up by microarray. This loss means loss of genes. These functions of the genes are lost here. That is why we are seeing all the clinical manifestations.
How would you counsel this family, Dr. Pradeep?
Yes, ma'am. So these microdeletions, if the microdeletions are there, it is very important to know whether parents are carrier or not. So it is very important because it will impact on the recurrence risk. If the parents are not carrying this microdeletion, the recurrence risk will be very, very low. It is almost less than 1%. But again, if the parents are carriers, the recurrence risk can even go up to 50%. It may behave like autosomal dominant. Here, these microdeletions may not be there as such in the parents. They will not be having this microdeletion, but they may be having a translocation involving this region. 2q region. Maybe there is a translocation involving second chromosome in them. That may be a balanced translocation. Because of that, parents are normal. So I would advise parental karyotyping here. Look for any balanced translocation involving these regions. If that is not there, this has happened accidentally, de novo sporadic, recurrence is low. If some parent is carrying this translocation, maybe prenatal diagnosis in next pregnancy is warranted to prevent a baby being born with the same disorder.
Thank you, Dr. Pradeep. We'll move to the last case. This was a 30-year-old lady came to the genetic clinic because she wanted to plan her pregnancy, and the history was she has a 15-year-old younger brother with intellectual disability, behavior issues, and delayed speech. His karyotype is normal. She brought the karyotype, it is normal. Somebody had done a sequencing for her, CES, and that showed 2 variants of unknown significance. She was now in a dilemma because she doesn't have a diagnosis for her brother, and she's worried whether she might end up with having a baby with a similar condition. So she came to the clinic for planning her pregnancy. I would like to ask Dr. Pradeep, in this scenario, is any further testing needed for the brother of this lady?
Yes, ma'am. So we have not got any diagnosis here. Testing has been attempted, but it is not complete. We are not going to give anything based on the result to the sister who is planning pregnancy. So thing is, karyotyping is normal. Obviously, we can understand a child with intellectual disability. Karyotyping can be a first level of testing. But before doing clinical exome sequencing, we should have some clinical diagnosis. So we maybe this would have been attempted blindly. Because of that, we don't how much ever phenotype you are giving. Based on that only, lab will give you the proper information of the genes. So they have given two variants, particularly these are variants of uncertain significance. These means class 3 variants. That is, these are not so significant. These are non-actionable variants. Labeling a child based on these results or taking steps for prenatal diagnosis, testing the fetus based on this is not allowed because these are non-actionable variants. We need to fix with the phenotype and genotype match. Here it is given as idiopathic generalized epilepsy. Epilepsy nowhere mentioned here. So epilepsy is not there. So again, whatever it is there for this variant, it is associated with seizures. Here itself we know seizures are not there. Maybe this may not be the mutation we are looking for. Another one is intellectual developmental disorder. This is again a variant. Maybe this may have some match, but again it is again uncertain significance. Based on this, doing testing in the sister or planning testing in the sister's fetus is not recommended. We have to complete here, maybe a male child, we have seen in the previous cases, a male child, intellectual disability, karyotyping may be the first line, but again along with it, Fragile X syndrome has to be done because that is the commonest cause of intellectual disability in male children particularly. So with some features related to Fragile X, I would prefer completing Fragile X and then look, maybe if needed, even microarray also, like in the previous case, then take a call on sister.
I'd like to ask Dr. Kiruthika about the Fragile X testing in this boy. Can Fragile X not be tested by karyotyping, microarray or NGS techniques, or does it need a special technique?
Thank you, ma'am. Yes, we need a special technique here because the karyotype or NGS platform as well as the CMA is not going to pick up this because it's actually a trinucleotide repeat sequence which is present in every individual. So everyone have the trinucleotide repeat sequence in our body, in the genome, particularly more on the intronic and exonic regions. Everywhere it is present. And generally it is of the count of the trinucleotide repeats which makes more sense here. And it can be picked up by a PCR technique which can be used as a screening tool. And what happens is when a person, there is a specific count of the triple repeats in our body, when they cross the count beyond which they are being named as having a Fragile X syndrome. So doing a PCR technique here will point out the frax repeats, and we also have another technology which is the Southern blot technology, where we can see what is happening there, like the methylation of this triple repeats. So what happens is when these triple repeats are increased, the FMR1 gene is getting methylated, so the expression of which is being silenced. This is what happens in Fragile X. So we do need a special test here. Symptomatic, or she can be partially symptomatic based on her X chromosome lineations. And when it is coming to pre-mutation carriers, we all know that there is a term called anticipation happening in triple repeats disorders. So what happens is when if there is a grandfather who is having a pre-mutation carrier status, that is his repeats are between 55 to 200, and when he is transmitting it to his daughter, there is a chance that the daughter might be in a pre-mutation status or she might be entering into the full mutation status. So what happens to those pre-mutation carriers is the grandfather tend to have a later onset neurodegenerative disorder where he can have a tremors, ataxia associated with that, and the carrier female, the mother, when she is having in a pre-mutation status, she might be developing what is called a premature ovarian insufficiency due to less than 40 years of age, which is due to the pre-mutation status in her. And when there is an intermediate status, we tend to see that there is a risk of developing into a pre-mutation carrier in the upcoming next generation. So what we do here is doing an investigation will let us know what kind of status we are, and so we can give genetic counseling to the family members for this pregnancy, present pregnancy, as well as in the future pregnancy. The risk can be offered to them. Recurrence risk will be known.
So how would you counsel this young lady who's wanting to plan her pregnancy? The question is to Brinda.
Thank you, ma'am. So, if we have confirmed genetically also the diagnosis of fragile eggs, one possibility for the proband who has approached us with pre-pregnancy counseling is to check if she is a pre-mutation carrier on one side, and if she happens to be, then also counsel whether extended family needs to be tested, so that like madam and sir had mentioned, they may be at risk of the ovarian insufficiency and the ataxias at a later point. So it is going to benefit the entire family in this scenario. So getting her or suggesting that she get tested is going to be very crucial in helping us figure out if the extended family is also going to be involved in this diagnosis or not. So that's how counseling would be proceeding. Thank you.
So this is a small algorithm when how we plan genetic testing in developmental delay. A detailed history is very, very important. 3-generation pedigree analysis, spend more time on pedigree analysis, and a head to foot examination of the child looking for minor malformations, major malformations, and then also neurological evaluation would also add help to hone to the diagnosis. And then if you reach a specific diagnosis, see your child fits into a definite genetic syndrome, say Down syndrome, you can plan karyotyping, or if it is a Williams or something like a microdeletion syndrome, Williams syndrome, or 22q deletion syndrome, you can do FISH. These two, I'm mentioning these two tests because they are cheaper and it is freely available for us everywhere. And then if you're sure it fits into a single gene disorder like neurofibromatosis or tuberous sclerosis, you can do Sanger testing. And when you don't have identifiable cause, you can go to microarray. You have a child with mild dysmorphic features development, as you saw in the third case, you can go to microarray. The microarray, if it turns out normal, you're convinced that it is because of a copy number variant, you can still plan a reanalysis, ask for a reanalysis for the concerned lab after 6 months or 1 year, you follow up the child. Then if that also turns out negative, you can go to genome sequencing. And or if all this comes negative, CMA is negative, and you are now thinking that it could be some other genetic problem, you can think of whole exome sequencing, which has now the new labs, the new technology helps them pick up even copy number variants. And if it is a VUS, you get a report with a VUS like what we saw earlier. You would ask for reanalysis, you can do rephenotyping, call the child, do more deep phenotyping. Then if all that turns out negative, the last resort would be genome sequencing, and which is very expensive, and you can also plan segregation analysis. If you get a pathogenic variant like that, what we got in the first case, we can do, it came out pathogenic variant in Rubinstein IB, then you can plan targeted parental testing of the same gene to study the segregation pattern. So genetic testing and a genetic diagnosis gives a lot of benefits. So though I'm not claiming that it is going to be the end, it is going to give you the answer every time, but it is very, very helpful for the child. It means changes in medication. If it is related to a metabolic disorder, IEM, then it may be dietary change in the dietary regimen or changes in medication. Newer therapies are there, research, gene therapy, organ stem cell, ERT. For the family, it's the end of the diagnostic odyssey. They have an answer. They know they have an answer. The uncertainty is over. They know now the pediatricians can spell out the natural history of the disorder, what are the preventive management that they have to look out for, and most important, they can plan. If they want another child, they can plan. Reproductive options are there, prenatal testing, PGT is there, so they can go forward. For the pediatrician, the avenue is like you can plan subset specialist involvement. You can, for example, a Down syndrome child, you can send them for to the cardiologist for an echocardiogram and do the endocrinology evaluation. You can plan developmental support, and once you have a diagnosis, you can plan your goals accordingly to bring the best from this child. Thank you very much for your patient listening. I hope you enjoyed it. I thank my panelists for this very interesting dialogue.
Thank you, madam, for this very excellent session. I think it was very interactive. Thank you.